Good afternoon and welcome to our first webinar in the VHHA's 2019 Reducing Preventable Readmission Series. My name is Joyce Davalt and I'm Director of Performance Improvement here at the Center for Healthcare Quality at VHHA. On behalf of the VHHA Center for Healthcare Excellence, we would like to welcome all of our colleagues across Virginia Hospital team. Next slide. Via email this morning. Please use the telephone option audio pin prompt and know that all participants are muted. We ask you to be engaged, and at the end of the presentation, please type your questions or comments in the question box that you see acknowledged on the right-hand side of your screen as in the picture here. And finally, also, our feedback survey will launch at the completion of the webinar, and we appreciate your input as we continue to build and direct our program. Next slide. The purpose and objectives of this webinar series we put together for you are to share successful strategies in use by Virginia hospitals and healthcare systems to improve care transitions and to reduce hospital readmissions, and to increase the transparency and facilitate networking between you, Virginia hospitals, your systems, and your community partners. Next slide. As you will see here on the table, this schedule features a number of hospital systems who have graciously agreed to share their success stories for this series, and we are deeply appreciative of their generosity and their time. As you'll see the dates there, we are every fourth Thursday, except we skip, of course, Thanksgiving, and our last one will be on December the 5th. Today's presentation is being presented from the Inova Fair Oaks system. I'm very glad to present our colleagues today and from the Fair Oaks Hospital and their transitional team service staff. This presentation is entitled Reducing Readmissions Through Collaborative Teamwork. Dr. Michael Lynch, who is Chief Medical Officer at Fair Oaks, will lead his team, and you see the names there, also including Agnes Deepin, who's Director of Case Management, Dana Green, Director of Transitional Care Services, Nancy Dean, who's Quality Consultant for Lynch and his Inova team.
I did want to say that we all know that readmissions is in the Medicare diagnosis area is very concerning. It is a penalty-only situation. We know very well about that. Our readmission, about 3 years ago, we had to pay back $594,000 to the federal government. Not a happy sight. So we set on a journey to try and reduce our readmissions. What we want to present today is that journey that we've been on for these last couple of years, and also to give you some ideas of things that you can do at your hospitals. Next slide. Just a little bit about Fair Oaks Hospital, if we can. We are within the Inova healthcare system. It's a 5-hospital system in Northern Virginia. We're a 182-bed acute care community hospital, and we have a number of things we're very proud of. We're in our 3rd redesignation of Magnet. We are one of 4 5-star hospitals, 5-star CMS hospitals in the Washington, D.C. area. We've had straight A's and leapfrog since 2012, and just recently we were named to HealthGrade's top 100 hospitals in America. So we have a relatively active hospital with 14,000 admissions and about 18,000 surgeries, both in and out patients during the year. Next page. We wanted to show you our Medicare-focused diagnosis work through 2018. As you can see, we use the Premier database to give us our information. Our goal is to get to the top quartile, but our goal at our place has been to get at the top decile. And we did achieve top decile performance in the 5 Medicare-focused diagnoses that we do here at the hospital, with one exception, and that was COPD, in the top right-hand corner, where we missed it by 1/100th of a point. Next slide. I'm going to pass the microphone over to Agnes Deedman, who's our Director of Case Management.
Hi, good afternoon, everyone. This is Agnes Steedman, and I'm the Director of Case Management. One of the things that we have identified as we have reviewed our readmissions the past year, we have to keep in mind that there are some barriers that our patients are having and need to be identified early on. So on a daily basis, the case managers will pull out a report from our EHR that lists all the Medicare-focused diagnosis patients. And this report indicates if the patient is a readmitted patient, if a case management assessment has been completed, and then we use a LACE index score. So the assessment, our goal is for the assessment to be done within 24 hours upon admission. Why? We recognize that the earlier we see our patients, the sooner we can work on the possible barriers to discharge and also develop a discharge plan. Our physician advisors review all our readmitted patients to determine if the patient should be designated as an observation patient or if the patient's meeting inpatient criteria. This is the process that we follow 7 days a week, as we have a PA coverage 7 days a week. The case management team with the physician advisor hold a mid-shift huddles from Monday to Friday. And during the mid-shift huddles, all Medicare-focused patients are being reviewed. If the patient meets criteria for inpatient, then that patient is, we give the patient inpatient. If we determine that the patient can be managed less than to midnight, then we have a discussion with the attending to see if this patient can be switched to observation. Weekend case managers follow the same kind of process. They review the patient's admission and then communicate with the PAs as needed. Next slide. As I've mentioned earlier, initial discharge planning is done within 24 hours of admission. And this is something that we have committed to and kept monitored on a daily basis. Some of the barriers that are being addressed by the case managers are sometimes patients are having problems with prescription, filling them up. We do have an outpatient pharmacy here in the hospital, and we highly encourage our patients to fill up their prescriptions before they get out of the hospital. That way, a bag of their medications are delivered to their rooms, and the nurse who's discharging them can go over those medications, and patients have the chance to ask questions. Patients and family members have the opportunity to ask questions on those medications. Our goal is for all our patients to go home with a filled prescription from our hospital. And last year, 57% of our patients had their prescriptions filled before they left the hospital. If the patient's not able to provide, if the patient's not able to financially afford the prescriptions, it is our commitment to make sure that the patients go home with the important medications, so we would help them financially filling up their prescriptions. The other thing that we would like to do for our patients is to make sure that a PCP, the patient is seen by the PCP within 48 hours of discharge. And this is something that we talk to them about at our initial assessment and let them know that this is part of their service of case management. It's, and for some reason, the patient or the family would prefer to make their appointment. To ensure that there is a 48-hour touch point, we would send a nurse to their house, and this nurse would be the one going over patient's medications. They will review the discharge summary or the discharge education. We would ask, the nurse would ask them to pull out all your medications, and we can go over them again and also check the vital signs. If for some reason the patient does not have a PCP, we have a transitional clinic wherein we would send our patient there. We would arrange a follow-up appointment with our transitional clinic, and they're the ones who would be helping them assist the patients with finding a permanent PCP. We would also give them a list of our community physicians if they prefer to do that. Next slide. The inpatient case managers work very closely with our transitional care manager. Dana Green is here with us today, and she'll go over in detail what our transitional care team does in the later slides. But for the most part, they are considered as an extension of our service. As we transition our patients in the community, it is important that a good handoff is provided. So all our Medicare-focused diagnosis patients, any social determinants that we identify, we want to make sure that they are being transferred or being handed off to our transitional team. In addition, if a Medicare-focused diagnosis patient is being discharged to a skilled nursing facility, again, the handoff is very important. We make sure that a discharge summary is sent to the nursing home that's receiving the patient. There is a checklist that's completed by the case manager and the floor nurse, and this is we go over this with the receiving nurse at the facility. We make sure all the orders are there and completed, and then we give a handoff report to the nurse who's receiving the patient as well. Next slide.
Hi, this is Diane Wilhite. Nancy Dean is also here. She's a quality consultant. And in 2018, we became aware of just the need to do a little bit more in-depth review of cases in the hospitals and really take a look at why patients were coming back. And so we decided that we would create, if you could go to the next slide for me, we created a weekly huddle that allows us to consolidate our physician advisors, coding and quality, and our chief medical officer. And each week, what we do is, and Nancy is instrumental in making sure that we identify all of the Medicare-focused diagnosis patients that are in the hospital with a LACE score of greater than 10. And we begin by reviewing all of our readmission cases and to really drill down into what were the reasons that the patient came back to the hospital, and what can we do differently with a system approach or as a programmatic change approach. Because our readmissions, thankfully, are so low, one of the things that we decided was that we could get ahead of it even further. So we began reviewing all index admissions for these Medicare-focused diagnoses to identify potential barriers that are already in place, and that since they're here in the hospital, we have the opportunity to eliminate those barriers and to implement strategies to prevent a readmission. So our focus really went from a readmission review to more of an index admission review. Because then we were able to really make an impact while the patient's here, and to prevent them from coming back in the 30 days that follows their admission. So we look at documentation of medication education. We look at palliative care assessments and whether or not the consults are being done. We look at their current rehab needs. And what that current status is. We look at the case management assessment and any social determinants of health to make sure that if something's identified early, we can establish a fix, if you will, to any barriers. If you go to the next slide, the program through this weekly huddles, first it was a collaborative process for reviewing these Medicare patients while they're in the hospital. But one of the first things we identified was that we needed a better way to do COPD teaching, and we got our respiratory therapy department involved in that. And so that teaching is actually being done now in the hospital by our respiratory therapists. We also implemented congestive heart failure teaching, and not only by our nursing staff, but with pharmacy assistants, especially related to medications. And then we were really looking to improve and increase our family involvement with teaching and aftercare. So some of the examples of things that we were able to do, one of the, we've arranged palliative care consults while in the hospital. We've also worked with our transitional care management people to make sure that if it doesn't get done in the hospital, that both hospice and palliative care assessments or follow-up is done after discharge. And we also, just one example was that we were particularly challenged with a patient who is homeless and had struggled with COPD, and really, she came back a lot. She was a repeat readmission. So we ended up purchasing a portable oxygen concentrator for her, something that works in the car, so that to try to keep her out of the hospital. And so just through weekly dialogue that lasts somewhere between 30 and 50 minutes, that we are able to set forth in motion strategies to help keep patients out of the hospital after their discharge. And I'm going to turn it over to Dana Green, who is our Transitional Services Director, and she's going to talk to you a little bit about Inova's Transitional Services. Next slide, please.
I'm Dana Green, and I'm the Director for Inova's Transitional Services, and we are essentially the department that is responsible for helping all patients coming out of an Inova hospital with their transition into the community. We're tasked with making sure that patients are safe and that that transition happens as smoothly as possible. Next slide, please. We do this in 3 different ways. We have 3 teams. So the first team, and the one that's probably most connected to the readmission reduction strategy, is our case management team, and they are responsible for patients from the day of discharge into the community for 30 days after that discharge. You can go to the next slide. They specifically focus on a number of pillars during that 30-day case management process: physician follow-up, medication reconciliation, red flags and teach-back, disease self-management, advanced directives, depression screening, and psychosocial case management. They are essentially exactly what Agnes said. We are the extension of the inpatient case management team into the community setting. We partner with the hospitals as well as with all of the community entities, whether it's the home health agencies, skilled nursing facilities, whatever it is in the community that is also helping to coordinate care for those patients. We also have hospital liaisons, which have really been integral in ensuring that the inpatient and the outpatient really come together as one unified team, which in my opinion has really kind of been what has made us all successful, is bridging the gap between inpatient and outpatient. That liaison meets with patients prior to discharge, sets them up for expectations, and really understands, helps the patient to understand what to expect after discharge, and then also coordinates care and has handoffs with the inpatient case management team to ensure a safe and smooth discharge. They also help to participate in readmission huddles, readmission meetings, and chart audits and ACAs to help figure out if something did go wrong, what was that, and how could we improve in the future. Next slide. We also have a Navigator team. This is a non-clinical team that really is responsible for all of the monitorization of the Medicare-focused diagnosis patients in the community. This is the newest group for our team, and I think of them as air traffic control. They're responsible for knowing where every Medicare-focused patient is in the community at any given time and what clinical provider has authority over that patient's care. They help to coordinate care, make sure that handoffs happen exactly as we would hope that they would, help to fill in gaps where there might be gaps or barriers. And one of their biggest and most important roles, in my opinion, is communicating with the primary care physicians and making sure that those PCPs know where their patients are in the community, regardless of how many transitions happen within that 30-day period of time. They're responsible for making sure PCPs are very well informed, and also in getting clinical documentation to PCPs if there's a gap in care somewhere, or if that PCP needs additional information. Their role is really to make sure that no patient falls through the cracks, and that at every single transition period, someone has eyes on that patient and helping hands at every turn. Next slide. We also have 4 clinics, and these clinics serve all Inova patients coming out of hospitalization or an ED visit, regardless of payer source or diagnosis. We're a post-hospitalization clinic that is staffed by hospitalists and nurse practitioners trained by hospitalists. Really what we're trying to do here is capture the most vulnerable patients who have inadequate follow-up care. And by vulnerable, it's really about the medical need for these patients and making sure that patients are wrapped around for that 30-day period of time after discharge. We stabilize them. Our providers have a comfort level with much higher acuity than probably an average community physician might. And oftentimes, care for patients that are still in acute symptomatic needs and really are able to follow those patients in a far more intense manner. If there's 30-minute appointments, we're able to follow patients multiple times a week, and we have a full range of services to include case management, pharmaceutical assistance, and anticoagulation management. And so we help to make sure that any patient that needs a more intense level of care post-discharge gets that, and we partner with our hospital partners as well to make sure that those patients are identified and captured for services. And I will hand it back to Dr. Lynch.
Next slide. We want to thank you all for hearing our story. We'll be happy to answer any questions that you might have.
Thank you, Dr. Lynch. We are monitoring the question box to see if anybody, if you're interested in asking a question of the team, please type it in the question box for us and we will convey that to the team. The first question, Dr. Lynch, that we have, do you have a legal review or an OIG? Where did it go? I'm sorry. We're trying to find, where's the question? Right there, it's right there. Okay. Did you have a legal review or an OIG review of the free nurse home visit after discharge? Is this not considered an inducement? Thank you.
I don't believe it would be an inducement, but we've not had it reviewed. Certainly, it's been out in the open throughout our system for about 2 years now, and our attorneys have never said that there was a problem. Dana, do you have a comment?
So one of the things, obviously there's lots of concerns regarding regulations around how things are done, but what I can say is that certainly we work with all the home health agencies in the community to help support those initiatives for home visits. And it's something that's paid for through the hospital, but again, it's available through all home health agencies, and we make sure that patients have choice as to what home health agencies they're using. So it's not a specific agency. We're working with all of our community partners to support that initiative.
Thank you. Any other questions from the participants or from the audience? Dr. Lynch, it appears we don't have any further questions at this point, but if I would go to the next slide. I would like to thank Dr. Lynch and all the members of his presenting team for just an excellent presentation today. Appreciate the audience, your patience in our technical difficulties, but we finally got there. Please remember that our next presentation is scheduled for May the 23rd, and it will be at the same time frame, 12:30 to 1. Thank you for attending, and we ask that you take a moment as soon as you click out of the webinar to do our short evaluation survey. Your feedback is very valuable to us. So thank you, Inova Fair Oaks team and your transitional team. We appreciate your time and your generosity today.
Thank you. Bye-bye.
Bye-bye.
Bye.
You guys want to hear what happened?